I'm delighted to welcome the esteemed guests and our distinguished panelists here to Healthcare 4.0 here at ISB. I'm Dr. Alekya Singapore, founder and chief dermatologist of the Skin Sensei Skin and Hair Clinics in Hyderabad, a proud member and also the branding and communication champion of AMPH Core 2024. Our topic for the next panel discussion right now would be unpacking the potential of tech-led decentralized care model. Before we introduce the panelists, I would like to add some words about the topic that we will be discussing now. It's the key to delivering an inefficient, decentralized healthcare model lies in the adept utilization of technology. This panel will unravel the intricacies of tech-led collaborative care model and its impact on provisioning of primary, secondary, and tertiary level of healthcare. The panel will list down the challenges and opportunities of transformative ideas that have the potential to scale up this field. The panelists will delve into crucial roles played by technology, companies, and healthcare organizations for a tech-led decentralized healthcare model. I would now like to invite our panelists. The first panelist here with us is Professor Vishal Karungalam, Clinical Assistant Professor, Information Systems ISB, and he's going to be the moderator of the session. Professor Vishal is leading a team of product managers on a mission to make data-driven decision making accessible to every user. He has been the principal product manager leading Microsoft's data drive agricultural initiatives. He carries management experience in leadership roles in supply chain, cloud, agriculture tech, data and analytics. Welcome, Professor. Our second panelist for the day is Dr. Amit Malik, MAHA Health, a doctorpreneur who founded Amaha, I hope I'm pronouncing it right. Amaha, one of the largest, India's largest mental health organizations, delivering accessible and high quality treatment, care and support in 15 plus languages with a team of 150 plus psychologists and psychiatrists. Welcome, Dr. Amit. And our third panelist is Sameer Swarkar, CEO of Neurosynaptic Communications, enabling access to quality and affordable healthcare to masses in rural and remote areas through proven e-health and m-health technology solutions with special focus on primary care, NCD management. We welcome Dr. Sameer. Our next panelist is Dr. Saujanya Kunapareddy, CEO at Relive Healthy India Private Limited. She is also a member of AMPH Core 2017, AMPH founding class. She's an obesity physician and lifestyle medicine consultant, spearheading technology-related initiatives and interventions as part of her clinical work. Welcome, Dr. Saujanya. Our next panelist is Dr. Sujana Priya Uba, consultant radio oncologist, AIG Hospital, new generation radiation oncologist with clinical knowledge of being exposed in a tertiary center and working with faculty of international repute. Welcome, Dr. Sujana. And our next panelist is Vaibhav Tiwari, co-founder and CEO, Portia Medical. Actively involved in coaching and mentoring entrepreneurs and senior executives, also serve as a board of director, advisor, and mentor for many fast-growing companies across internet, retail, consumer, and technology verticals. Welcome, Vaibhav, sir.
All right, thank you so much. I just want to make sure you're all able to hear me, yeah? It's fine? Great, okay, awesome. First of all, it just feels such a privilege to be, with this group and with this audience. I just want to say thank you before we start the panel. It's always a good experience to talk to people who know so much about the field that we're going to talk about, and hopefully all of you will feel the same at the end of it, and we'll also give some time for you to ask questions towards the end of the panel. So if you are having any thoughts and if you want to talk about anything, and as the panel is going on, if you are having some new ideas, please make a note of it. We will strongly encourage all of you to participate as well, okay? So before we start, I guess the first question I have, and it's really a question for all of you, is if you could just throw some light on how have you seen the world of healthcare delivery transform because of technology? More specifically, what kind of changes have you observed in care delivery, whether it's decentralized care delivery or technology, how it's actually transforming this whole space. And I'm sure the context that each one of you is operating in is slightly different. So it'll be great to get each one of your perspectives based on your context. Maybe we'll start with you, Sameer, if that's okay. We'll just go in the order.
Sure. Thanks, Vishan. Am I audible? I have a little bit of a voice problem, so I thought I'll check first. So, Neurosynaptic works into the rural healthcare delivery through technology. We have been at it since about 20 to 21 years now, and one of the oldest or one of the earliest digital healthcare technology company. So, we have seen many changes as they happened in this domain. While we started with the belief that the last mile healthcare is best done through the digital technologies because of scarcities of infrastructure, scarcities of skill set available, and the absence of various facilities. What we have seen is initially sort of a experimentation, stumbling development, etc. And then that suddenly got a change of gear post-COVID or because of COVID, I would say, where suddenly all the shortcomings or shortages at the last mile came to forefront, became highlighted, and everyone focused on them. And it was initially started a little bit with, I would say, pre-COVID, where we had the digital health policy already. We had the ABDM introduced, and we had some sort of initiatives like Janaushadhi, etc., already put in place. But then we suddenly had, on one very fine day, the telemedicine guidelines opened up, and that enabled, on one side, the clarity on policy that yes, such technologies are legally okay to offer, or such services are legally okay to offer at the last mile. At the same time, it also sort of demolished, I would say, doctors' barriers, a lot of barriers that we had from the doctor's side in terms of opinions of providing care through technology at the last mile without having a physical doctor present in many cases. So I would say that this is a transformational phase for the digital healthcare in India, where since last 3 or 4 years, we have seen opening up of several initiatives enabled by the policies at the state level and fueled by entrepreneurs at all level. So may it be the digital devices side, medical devices side, where there has been a lot of development. May it be the service providers side, where there is a lot of platform or services, standard operating procedures developed for such remote healthcare. And at the policy levels, where we are actively encouraging digital health and wellness centers at the last mile, fueled by other mechanisms like Janaushadhi insurance and so many others like NCD programs, etc. So it's now, I would say, very well geared up for remote delivery, distribution, decentralized implementation of various things. And of course, technology is the one that is fueling it. So very appropriate topic, I would say. The only part I would have said was, I would have liked to say was, I would like to distinguish between decentralization and distribution, because at the last mile, while it is possible to implement various of these things, the decision making at the last mile is still very rare, especially in the public health sector. And I think we need a little bit of more work on that, so that a lot of things can be sort of quickly streamlined rather than waiting for certain approvals from the top levels, etc. So yeah, that's really.
Thank you. It's great perspective. I think a couple of things that you mentioned. One was about the guidelines coming in and helping you, get to the last mile. And second one is this distinction between decentralization and distribution. Thank you so much.
So
Thanks.
let me just
Please.
add to add to this as to what we do, so that we
Please,
can
please.
put it in context. So basically, Neurosynaptic develops a platform called Remedy and implements last mile healthcare delivery services using this platform. We also manufacture 40 point of care tests which cover the non-communicable diseases, communicable diseases, and maternal and child health related solutions which can be delivered through this Remedy kit at the last mile through the platform. We provide operational services at several PHCs, implementing teleconsultations, telemedicine, and operations and management at the primary healthcare centers. We also operate certain NCD programs, non-communicable diseases programs, in the interiors, creating awareness, collecting data, and providing appropriate care at that point. So that's, yeah, so sorry I missed that. So
thank you so much for the context. Very helpful. Thank you so much. Doctor?
Yeah, I come from a perspective of decentralization to the level of individualization is what I would say, not even the community perspective. This technology, the way it has disrupted the space, and thanks to COVID, the way telehealth guidelines have been structured in a proper manner. Pre-COVID, there were platforms, but we were not enabled enough. There were a lot of medical legal issues for us to give tech-driven solutions to individuals. And unfortunately, in the case of post-discharge care, post-hospitalization discharge care, or NCDs, everything happens outside the hospital, where there is no easy way to monitor, and that used to cause a lot of burden on the individual. So post-COVID, we just charged upon it. We sat back with the phygital model because we really wanted to understand individuals' comfort in staying away from the doctor and still taking solutions and advices, because COVID was altogether a different phase. Everyone was ready for everything. That's survival, but this is something entirely different. And it took us 3 years to really figure out the right touch points, and thanks to wearable devices, thanks to technology, thanks to digital solutions, we've come a long way from the point of just managing to the point of remission, because each individual's environment we are able to understand. Because of this current disruptive technology, we are able to leverage against. And the data-driven decision making, we are able to provide individualized solutions just because of the immense amount of data we are getting today. And it's all patient-driven because they are the users. It's their life that we are dealing with. Yeah.
No, thank you so much. Actually, you bring up a very nice point about personalization of care, and we'll talk about that a little later, but great perspective. Thank you so much. Amit?
So questions like this make you think about how old you are. and so I'm going to take a slightly more longitudinal perspective and talk about, I turned from a clinician to a clinical manager to business school, and then a business manager, and then an entrepreneur, right? So I've seen the entire spectrum over the last 25 years. And I'm just going to give you a clinical scenario, right, that existed 20 years ago to what exists now. So 20 years ago, when I started my residency in psychiatry, I'm a psychiatrist by background. I run a mental health organization, and you would have an emergency crisis at midnight where some local doctor would call some specialist center, and the patient would present to your emergency room, and then their case notes would either not be there, or they would have to be shipped in a taxi or in a car from somewhere to somewhere so that you can have this older perspective, or you'll have to spend 2.5 hours in a crisis situation getting the client to regurgitate their notes, and then you'd find out that actually this person was at risk but could have been managed remotely as well, right? This has happened, this is 2001, right? Today, and then that went to then EHR came in, and that seemed like, wow, amazing technology. And then you could access this person's notes on a computer in the middle of the night somewhere, and then that was a great. And today you can manage this person at home, right? Today you can use AI-driven data indicators to signpost relapse indicators, which will show you that this person who might be suffering from schizophrenia is actually on the path to relapse, provide early intervention, take care of them at home, get virtual consult with the family from a care coordinator or nurse coordinator, get their prescription done remotely, and all that care can be managed out of the hospital. There'll still be a smaller percentage that need to come into hospital, but you can do all this at home. So that's how care has changed. Now, there's obviously, I'm giving you two snapshots 25 years apart. Obviously been lots of steps to that as has happened, but but this changed dramatically. So the whole idea of looking at a more client or patient oriented service from a service oriented patient, if that's the right word to use, where you had to work around what was available or what the service structure was to manage your care, to now you have the opportunity, at least if it's not still happening fully, to manage your services around the client essentially. That's I think the big change.
It's very nicely put. So you're saying now we've started putting the user or the client at the center.
You could at least, you can at least, I mean you couldn't, 25 years old.
The attempt is there.
Yeah, attempt is there.
Wonderful.
Or the possibility is there.
The possibility and the intent, both.
Well.
Thank you. Great. Doctor.
So I'll give a slightly different perspective. I've been hearing all the lectures from morning. So technology, I mean, I might sound a little, definitely, but you know, compared to what Amit was telling. So I finished my training in 2013. So since then we have been exposed to EMRs, and most of my training is kind of, I've been exposed to a lot of, you know, technology driven, in technology driven thing. Even though I've done my training in a government setup, in a public health setup. So, but the thing is, morning also a lot of equity managers were there on the same dais, and they were talking about there's a lot of infrastructure gap. There were but that's actually not true. Every other day, even since morning, I've been getting a lot of calls. So if you see, even in North Bengal or even in Arunachal Pradesh, you have a lot of high-end technology there, but there are no people there to drive the technology. Every now and then I keep getting calls, please send me a radiation oncologist there, please send me a medical oncologist there. We have everything, we have immunotherapy, we have chemotherapy, we have everything, but we don't have people who drive the technology there. So that's the problem. So unimaginably, even in Hyderabad also doesn't have that kind of an advanced technology here in Hyderabad. But even North Bengal, Siliguri, it's a very small place. It has got 2 PET scan machines. So I feel very surprising to see all those things. So a lot of people, they don't invest in training after they finish actual training. They don't subspecialize and they don't really invest in some time to work in a specialty center or a proper high-end volumetric training center. They immediately want to get into practice. So what happens is, in our specialty, everything is, we work, so without a linear accelerator, a radiation oncologist is nothing. So what happens is, we work on a cloud-based platforms. So what happens is, if someone needs my help, so they usually ask me, okay, we have seen this patient, we have advised for radiation, but you need to help us as to how to delineate the tumor, what are the margins you need to give to the tumor, and so implementation part will take care of it because the patient is there. So they'll probably send everything through the cloud. I'll import in my system. So it's all completely, the patient data and everything is anonymized. The names and everything is anonymized. So I'll have to contour it because because I'm in a tertiary center. I'm not somewhere in a peripheral center. I've got more experience with dealing with a lot of those kind of patients. So I've explained, okay, these are the nodal levels you have to include. Because these are the, you know, these are probably, you might have some nodal failure here and there. So that's how we contour, and finally the planning is done, and finally we send it back to the person there. Somewhere, maybe, I mean, I'm just giving you an example. Yeah. Somewhere in Northeast or somewhere in the North, somewhere in Jammu Kashmir, and the patient is implemented there. So, and in this collective decision making, sometimes I keep getting cases for reviews. I somehow feel that, why does this patient even need radiation? But if I call back my colleague and ask him, okay, why did you even advise for radiation? So they say, madam, ho gaya to ho gaya, kuch na kuch karke bhej do na. So that's the kind of answers I get. So I think the emphasis on training is also should be there. So nowadays, because of the technology, the world is open. The world is open. It's not like someone has to come and hold your hand and teach you. But still, a lot of people don't take that step, the extra step or extra mile, and don't do that. But yes, definitely the world is open. So I think technology has really enabled in this way, at least, to get involved in patient care and really helping them out.
Great. No, thank you so much. It's a very interesting perspective, and we'll go a little deeper into that as well, specifically in trying to understand what kind of impacts does decentralization have, whether it's with respect to continuity of care, quality. We'll talk about that in just about a second, but Vaibhav, please, your perspective.
So from my perspective, Portia is India's largest outside the hospital healthcare services company. So we basically provide all the possible healthcare at patients' homes, which includes basically setting up as critical stuff as setting up a full-fledged ICU at home to probably as simple as picking up a blood sample for diagnostics. And from my experience, and Podia is the 11th year of our operations, and from my personal experience, what technology does for decentralized care, okay, it probably allows decentralized healthcare companies to become profitable. Because people have been in this space, and some of you who have started ventures will know, in decentralized care, basically healthcare is a lot about clinician, right? End of the day, as we are saying, patient is there's a possibility for it has to become patient-centric today, but reality it is clinician-centric. And a doctor is sitting with us, right? It's unlikely that it will ever go it will never be clinician-centric. It will always be clinician-centric because it's very skilled thing to do, right? And if you are doing decentralized care and you want to scale it, there's only one way you can scale it, and that is leveraging technology. And only by scaling it you can make any business profitable. So if you ask me, it makes all decentralized care viable as business options and gives them a lifeline to make it profitable at some stage actually. So all the business plans which we make for our VCs and investors, with technology at least there's a real chance for it to come together actually. So I think that's at a broad level, but at the next level, it also makes it much more scalable. As in our case, itself, I'll give an example. When we started physiotherapy services at home, right? And the physiotherapists had to go to patient homes, and if they were not going, they were SMSing us 11 years back, saying that, okay, I'm not going. And with the scale, by the time somebody ends up reading all the SMSs, the visit has not happened, and patient is shouting at you saying that the guy has not turned up, right? And from then saying, okay, now you can use the app and you basically have it available with you, and you can track the clinician, and you can make sure that patient knows well in advance that the guy is coming, not coming, service can happen. So it has really made it scalable. At that time, you just couldn't make it happen at any scale. Today, with technology, it's becoming scalable. And I think the last point, which is very important, which Amit also mentioned, I think there's a real chance for now healthcare to become patient-centric, especially for chronic disease and other things which are lifelong. You can really create the treatment plans for patients, and you can really work with them to offer personalized care. And we are seeing that enough action in our setup, and quite a few new startups are coming. We're saying that can you make it really personalized healthcare? I think that's the future of healthcare, and as we know, everything in healthcare is slow. So if we say there's a possibility to make it patient-centric, maybe it will happen in next generation, but it will happen sometime. Technology offers you that chance to do that.
Yeah. Wonderful, wonderful. No, it's a very, very good perspective, both in terms of the viability of business, the scale of the business, and in some sense improving quality and service levels, right? So all of that's kind of coming together. But we'll stick with you. I think the home care business is a very interesting business. If you think about it, it's not something that you can accomplish alone. You're probably accomplishing it as a part of an ecosystem. So in this whole decentralized care delivery mechanism, what does that ecosystem look like? Who are the big players? Like, how do these players work together? What are the roles they're performing?
So what happens, at least the way we define ecosystem, and that's an interesting point, the way we started the business also, we set up the capabilities. So we said we can do like ICU at home, or we can do nursing, or we can do medical equipment, physiotherapy, XYZ, all capabilities. And then basis of capabilities, we create solutions and said, in the given ecosystem, who are the people who can use it? So obvious one, of course, are hospitals, right? The patients are in the hospitals when they are discharging. They require good care at home, and we take these solutions in a packaged form and give it to the hospitals. So of course, hospital become one critical part of it. Doctors became an important part of it actually. So we won't go and work with doctors directly, not necessarily only hospitals, doctors also. Then pharmaceutical companies became very important because by law they cannot directly access the patients, but everybody wants to get to the patient. So it became very important for them to leverage home care, and we are like the last mile connectivity, right? We basically do. We handle anywhere between 15 to 17,000 patients every month. So we are spending more than 1 million hours in patient homes a month. So I have that kind of like last mile pipe in patient homes. So everybody in the ecosystem who wants to use that can use that, right? So pharmaceutical companies is another important point. Corporates is an important point. They want to offer primary care and home care for their employees. And of course now insurance, because insurance is not a big player in this. Now insurance, post-COVID, insurance also is looking at how they can leverage home care basically, and how insurance is creating policies which cover home care. Earlier it was not covered directly. Today there are specific solutions which insurance companies are covering. We're saying if you are sick, Under these conditions, you don't need to come to the hospital. We'll take care of you at home. Players like Portia and others will come to your home and take care of you, and insurance will cover it, right? So there are 5 ecosystem players, I think, and of course the 6th one is patient themselves, so we have to work with them. And we are seeing very interesting models in, especially in pharma companies and all, where they are looking at how they reach to patients through various services, how they can really create value-added services for the patients, which didn't exist earlier, right? So we are running a program for a large company today in migraine management. So the device basically, it's a device which you can, it's like a patch, right? You can apply, and it helps you in migraine management. And there we do basically the end-to-end launch. We work with doctors to activate for them the whole patient engagement at doctor's clinic. Of course, we work with the patient to basically manage once the device is given to them. So from that perspective, decentralized care, the way I am seeing it, every single ecosystem player now, especially post-COVID, is looking at making it more strategic. And that's how the whole point of patient engagement comes into play. If you looked at hospitals 5 years before, for them, patient came, it's like episodic thing, right? You come, you go, nobody cared, right? Today, they are looking at how they create patient engagement models. And home care plays a big part of that. So I think something is saying, okay, it's nice to have service, to the must-have service, and our relationship with them has become a lot more strategic, quote unquote, in the last 2-3 years, is because they are looking at being a lot more patient-centric. So I would say healthcare being more patient-centric, and from that perspective, decentralized care and decentralized care providers become that much more important in the whole ecosystem.
Oh, great. No, it makes a lot of sense, especially the deconstruction that you did in terms of hospitals, pharma companies, corporates, insurance, and then patients. I think it's a nice way to kind of think about the ecosystem, right? But I go back to you, Samir. Like,
Sure.
How do you think about this in conjunction with the primary care aspect of all of this?
Yeah, so while most of the stakeholders remain almost same, there are some additional stakeholders in the primary care context. One of it, very important one, is the public sector, the health department, or I would say the public health machinery. Because whether it is a malaria program or a TB program, eventually you have to reach there to be able to get support for the patients. If you want to access some sort of an insurance, which is actually any personal insurance or health insurance private are lacking in the primary care segment. So you are basically going to go back to the PMJAY kind of insurance scheme, and so for accessing that, so we will need the government machinery. So one part of important stakeholder is the government. The second is the community, and basically it right from the awareness to the panchayat supporting the initiative, to the self-help groups being formed in the community for people to feel comfortable seeking care. If it is, for example, psychiatric care, then it is even more complex, or any care that has some stigma attached to it. For example, it's rare, but there is HIV, there is TB, and those things also start becoming stigma. So you need really a good awareness creation mechanism around it in case you are handling those. So the counseling, the community involvement, self-help groups, the panchayat involvement, and all of those things. The third aspect, and it is very similar to the home care part, I would say, is that there are certain segments of population who don't even come to 3 km for PHC, the geriatric population, etc. So, and also women. So there is a gender skew in the access part. So while it is a part of awareness, it's also, that different kinds of solutions have to be developed, or models have to be developed for these particular segments, because otherwise they will not be effectively implemented at the ground level. For example, for the geriatric population, you really need to develop something that reaches their home, even if it is medicine delivery or things like that. And since they are not the earning members most of the times, there is very cost sensitive stuff. So some of these additional considerations and stakeholders come into picture.
Wonderful, thank you. Because that primary care perspective, I think, is also very unique and important for us to analyze. So thank you so much for sharing that.
Absolutely.
The curious question I have, though, is I think we kind of started having that conversation, but I'll come to you first, I think, Dr. Saujanya, which is in terms of, we've been talking about all the advantages we're seeing. Are there any challenges you see with decentralization? Anything that you're seeing that is probably a challenge?
Main challenge, the most important challenge that I faced is digital literacy. And lots of different cultures, quite a wide array of age that we are dealing with in the area that we are working. And geographies, demographics, India is a very culture sensitive, highly limited place for a lot of things. All these limitations, people tried moving beyond those limitations during COVID. So a trust factor, thoda bahut, so we could establish, thank God for that, the upside of it, I would say. So that's where we were not pretty much confident post-COVID also, as I said. We tried to understand their comfort zone, and this digital literacy is still a challenge. But my dream always used to be reaching out to the last mile patient, and when we could connect to a tribal lady who can't even speak any of the 3 languages that we can speak and manage her health, I think technology did help us. We are getting there. We are trying to understand the end user than saying we know the end user. We've always been working in the area like we know what they need. Now we are working towards let me understand what they want and how they're comfortable with us, and that's still a challenge for us, and we've come a long way, I can say.
Wonderful, great perspective. We'll come back to you because I think this is like something that you've been talking to me a lot about in terms of what is good and bad about this whole decentralization, especially when you think about quality of care, continuity of care. What's your perspective on this as a practicing oncologist?
Yeah. So there is, especially as an oncologist, the patient has to, it's a chronic disease. It's a chronic illness. Previously it used to be, even now because of the latest advances in the molecules which are coming up, patients are living long enough, like 5 years, 10 years, 20 years as well. So as a continuum of care, for the patient to come send a PSA report for prostate cancer or just a CBP report before chemotherapy, you don't have to come all the way and schedule an appointment beforehand, come see the doctor and schedule an appointment for chemotherapy or hormone injection the next day. So you can as well just send a text message on an app, send the report on an app or send a text message on WhatsApp. That probably would suffice. So the other extreme is there's a lot of information excess. If you just have burning micturition, okay, what does burning micturition in a 30-year-old female mean? The first answer, carcinoma ovary. No, 90% is urinary tract infection. But immediately you get a message, madam, I have CA ovary. Who told you that? Google.
Yeah.
Dr. Google has told me that.
Best Google in the world, best doctor in the world.
Yeah. So that's another, so yesterday I got a message from one of my patient. So madam, I'm eating a lot of sugar. So because of that I probably had cancer. So obviously it's a WhatsApp forward. So I didn't know how to react to that. It's again information excess, and this message has been getting forwarded multiple hundreds and hundreds of times. So actual thing is the relevance of, I keep ignoring those messages, I don't even answer it. For example, if the patient has a temperature of 101 or 102, it gets buried in those unimportant messages. So you have this WhatsApp messages and in, madam, I have a temperature of 102. I obviously think that the important message gets buried in that. So it's like again a double-edged sword. So
I mean, it's a great point. I mean, the era of technology, there is one thing that we have in excess, it's data.
Yeah.
The one thing we don't have is good data. So I think you're absolutely on point of saying that. No, thank you so much for that perspective. I'll come to you on the same question though. So especially in the mental health space, how are you seeing this whole thing play out? Like what's working, what's not working as far as the decentralization is concerned?
See, access has improved dramatically, right? So today we provide care, one-to-one care to people from over 600 cities in India, which was not been, and there has been no access in the cities for decades, right? So that's become a big factor. And language is a big barrier, but we now do work in 18 languages just for that, because we do think that that becomes a critical barrier in terms of building the patient connect and then get into good outcomes. So I think that bit's working very well. And I think the information allows you to manage quality well at scale. So if you can leverage both quantitative and qualitative information and then triangulate it together, you can really start building a fairly good picture of both a client and also a clinician. Then that triangulation can lead you to sort of data boards that you can really leverage for effective management at scale, right? I think the two challenges that one has to constantly keep working towards. And there's a third one I'll come to in a second, but the two main ones are really around how do you manage quality, right? And how do you monitor and then manage quality, because it's taken us decades to get it right in the hospital, right? Or just about at least know how it works well in the hospital, right? And now suddenly there's a diffuse ecosystem where somebody's sitting at home and somebody, the client's at home or the clinician's at home, or they're both at home, or they're out in the community somewhere, and and then somebody's a supervisor in the clinical setting, and somebody's providing collaborative care. How do you manage quality in that scenario? How do you build data matrices that will allow you to monitor and then create actionable steps to monitor quality? That becomes quite important. So I think that's one challenge, and we can talk more about that. There's a lot of work that's happened around that. And the second is, by definition, decentralization leads to fragmentation.
Yeah.
Right now, suddenly everything was happening in the hospital. Yeah. Now it's all happening out there. So how do I then provide, especially for long-term conditions, right? How do I then provide continuous collaborative care? Because most of decentralization is going to happen for chronic conditions.
Yeah.
Or it's unlikely for acute medical emergencies you'll have decentralization. It's going to happen for chronic conditions. And so how do I then provide continuous collaborative care involving the client and the family? And then how do I keep monitoring outcomes around that? Right? So those two areas around quality management and quality monitoring, it's new. I'm not saying it's impossible, but it's definitely new in case of this. And then secondly, how do you manage collaboration in a continuous way? And third bit is about building the right kind of supply. So how do you build clinical supply of professionals of different skill mixes to create an effective decentralization model? I'll tell you why. Because the willingness to pay in a decentralized model is lower. Right? So while you'll happily pay that 4 or 5 lakh bill in the hospital, that comes is very different in a non-hospital setting. So now how do you create a skill mix that is appropriate and how do you do task shifting that's appropriate to create the right financial model to be able to deliver effective care? And then how do you manage, again, the collaboration and the quality of those things? So I think that's the third piece of the equation, is saying, in this new decentralized world, what does supply of talent look like, and how do you sort of bring it together to derive quality essentially?
It's a very good perspective, but just kind of pushing on that a little bit. In the mental health space, how are you seeing the supply problem being addressed? Is it being addressed? Is it a problem, not a problem? It's an area that doesn't really get a lot of limelight.
My whole life is about solving the supply problem in mental health. So I've now been working the supply side of mental health for 15 years in Europe and then here, and there's always going to be a shortage, right? So let's start by saying that nobody's solved it. It's not an India problem, it's a global problem. Nobody's solved the shortage of mental health professionals globally. But what we know is that India produces enough qualified professionals every year to meet the need in this country, right? Now the problem is, where is the skill and the training level to be able to then effectively manage good outcomes is where the gap is, right? I have the degree, I have the qualification, but do I know what to do with it? Is a gap that we experience a lot. So we employ about 175 fully qualified clinicians at different levels, from master's levels as a junior most to PhD level and in the psychology side, and then DM level doctors on the psychiatry side, right? And so how do you then bridge the gap? And I was talking to Nachiket earlier, any solution that relies on seeing the senior most clinician is not a scalable solution. Right? So how do you then build that supply side at different levels of skill? So we've set up a training institute. We knew that we are okay for now. We get about 17 to 1800 applications for clinical roles every quarter. We recruit about 2.5% of those because that's the skill gap, right? We need a lot more, that's the skill gap today. And so we set up a training institute with some as a not-for-profit, which is going to be just purely focused on capacity building, both in mental health, wider healthcare, and then the community. So community, because a lot of work can happen there, right? A lot of work can happen in the workplace with the HR professional, or in the school with the teacher, or in the community with the community workers. So how do you upskill that group of people will really be the long-term systems-based solution. But in the short term, we are going to focus on saying, we're getting 12, 14,000 psychologists coming out of grad school every year. How can we make at least half of them system ready to be able to serve the needs of what's already the overt demand today?
Got it. No, this is super good perspective. But I'll bounce it to you. How are you thinking about the capacity problem? Because the problem that he mentioned in terms of supply is very unique skill set. If you think about it, it's a very niche skill set, takes a lot of time. But this also is a very different skill set. Home care is a very different skill set, and you have multiple kinds of skill set that you need to cater to. It's not one anymore, right? So how are you thinking about capacity building, capacity problem? Do you have that challenge, and is decentralization kind of increasing that challenge or exacerbating it?
So this is a very valid point. I think there's a capacity is a big issue today in home care. It's like at one level, say India has 1.4 billion people, and it should be easy, and that like enough and more people are rural population also, but it doesn't operate like that. So if you see from nursing perspective, of course, nursing has been a skill in shortage in India for quite some time now, and with all the options available for nurses to go abroad, I think it's becoming only worse. But that's probably something which is controlled by government. So there's a lot of policy changes have to be required for nursing to become a viable career option. Of course, there has to be enough number of nurses, and it's become a viable career option in terms of, I mean, quote unquote ROI, right? I mean, nurses invest X amount of rupees in the college education, and how much do they get paid for that, right? And the salaries have to go up for that. That whole healthcare, the patient pay has to increase. Whatever you pay for the service has to increase. So it's like a big spiral. But the fact is that nursing is in short supply, and not only for home care. Of course, it's also in short supply for hospitals today. And there's like of course, there's a finite segment which everybody is chasing. But the other big segment of home care is on patient care, elder care, what we call, right, the bedside assistance. And that is something I think India's large population, especially rural and tier 3, tier 4 towns, is a real option to create skills over there and skilled population over there. And government, of course, invested significantly in that. So all this Pradhan Mantri Kaushal Vikas Yojana, that whole NSDC work, there's tremendous work which has been happening. Of course, it got hampered a little bit during COVID time because just like no centers were running. But I think there's again renewed focus on that. And we ourselves would have trained almost 30,000 carers in last 10 years. Okay. And so, I mean, one thing, of course, from first year now, that the trained cadre is available. The requirement is much larger. And then you are seeing demand for those carer even from countries like Singapore and Japan now, right? I mean, there is a program being run by government now on people, carers being trained on in Japanese, so they can go basically to Japan and do elder care, right? India has close to 13 crore people who are 60 plus, and India will have 35 crore people who are 60 plus in next 10 years. So it's bigger than US, right? The total population of US. So that's a scale which you are talking of from elder care perspective, and it's a real need. With I mean, one part is decentralized. Even families have become decentralized, right? So people are staying alone, right? So how do you take care of parents? I mean, today what we support, we do almost like 5,000 to 6,000 patients for elder care every month. In that, at least 20 to 30% of the patients are single people living in their homes with the carer. There's nobody from family who's staying with them. And it's just like a tip of the iceberg problem. I mean, there's something will only grow. So skilling for elder care is going to become very big. Skilling for things like dementia is going to be very, very big. India has 25 lakh people who have dementia today, recorded. So assume that like another 100% will be there, which is unrecorded. And these kind of things require really specialized care. So I think skilling in home care is a very, very critical part. There is some initiatives on government side, but a lot more has to be done now.
I think skilling is going to get decentralized. I think that's what's going to happen. That's already happening to some extent. And I think it has to happen. I think the combination, because you're going to be able to shift. I mean, you already are doing it. You're going to be able to shift traditional human tasks to machine. It's already happening. A lot of monitoring is getting shifted to automation. And then for the more complex tasks, you'll be able to skill people with specific tasks, and that'll get decentralized. So I do think that the era of getting a specialist nurse to do everything is probably gone. I think you'll see people doing very specific tasks and getting really good at them, and then working with a cadre of untrained but skilled people doing a lot of work with specific tasks, and then a lot of it happening through machines. So that's the only way we're going to be able to manage. I mean, I'm not kidding. There are more Indian psychiatrists outside India than there are in India. There are more Indian nurses probably outside India now than there are in India right now. So they're not going to, because the whole PPP perspective, they're not going to stop the brain drain happening. So you have to look at different solutions and different task shifting and skill mixes to solve the problem.
No, it's good perspective, but I would like to get your perspective as a practitioner. Yeah.
So most of the day today we're just focusing on sickness and health, whatever. So, but why not we focus on the preventive care? Yeah. So that is one thing which has been, going on in my head since morning. Unfortunately, we don't have a preventive task force in our country. So it's like we are a blind person sitting on a blind horse and driving towards a cliff. So we don't have guidelines, we don't have any screening guidelines or anything, and everything we are borrowing it from the West, including screening guidelines. So for example, if you take an example of NHS, so a lot of criticism has been happening for the last, I mean, if the king is waiting in a trolley outside, you know, who are we? So then, having said that, so what happens in NHS is, for example, everything is monitored because your state pays for your health. So you get a letter to your house once every 3 years that yes, you're due for screening now, you have to go. So your district nurse specialist comes and, you know, tells you that yeah, you're due for screening, either pap smear or a mammogram, or, you know, those are the only screening modalities which are approved technically. So these kind of things are, unfortunately, like I said, we don't have a preventive task force and we don't have any screening guidelines in our country. So why not we at least borrow the guidelines from the West for now, and why not we include everyone and make an app and just tell them that okay, once every 3 years, you know, you get a message. Like once every month you get a message from HDFC that your loan amount is about to get debited from your account. That way, once every 3 years, why not you're due for your mammogram, you're due for your pap smear test, you're due for your HPV co-testing. So these kind of messages probably, you know, that way probably technology might help is what I've been thinking since morning. Yeah.
No, that's great perspective, especially on the preventive piece.
Yeah.
Super helpful. Super
Yeah.
helpful.
Vishal, if I may add,
I was coming to
I
yes.
have a slight different perspective
Please.
in kind of the new wearable devices giving a lot of new data of the people that we have never studied about their environment. We see that a lot of solutions that we are traditionally are there in the books are pretty obsolete, and we need to come out with real-time advices that's suiting their environment, and AI modeling is helping us with that. I think a lot of AI model, the mundane skills of whatever textbook knowledge that we've been trying to pass on with a flyer or a piece of paper, charging something for them. Those things, AI is doing a better job in our case, and such individualized approach it is able to give. We really need to integrate the new age data also when we are talking. We are still stuck in the tertiary care to primary care, but there's a lot happening out there with all the wearable devices data that is coming through, which we are not really reading into it properly. And our nutritionist role has become much more sophisticated with the new age data that we got. Most of the solutions the AI is giving pretty good. We just monitor over it and suit their needs and suit their environment. I think we only suit their environment, not the real solutions. So there's an upside, definite upside to how much of skilling do we need when we integrate technology.
Yeah. No, that's great
I
perspective.
have a point to add to what
Please,
Sonia was telling.
please.
So in other countries, for example, if I've passed in 2013-14, so that's there for my life. My degree is there for my life. But if you go to the West, once every 5 years or once every 10 years, you have to take a re-credentialing exam. So unfortunately, that's not there here. So other thing is, so before you operate, for example, you're doing a robotic surgery. So you have to maintain a detailed log about how many robotic surgeries you have done. 150 is the minimum norm. For example, if you're a colorectal surgeon, robotic colorectal surgeon, the minimum norm to be certified robotic colorectal surgeon is 150 surgeries. It's not that you pass today and tomorrow you just claim to fame. Yeah, just say, okay, I'm a robotic colorectal surgeon. That shouldn't be the case. And once every 10 years or once every 6 to 7 years, you should revisit whatever you have done in the past, and you should take an exam. It's just that you're testing yourself. So that what happens, you take out your book and you read everything and you keep updated yourself with what's happening in the world. So just before me and Saujanya were discussing, so the concept of BMI is not there anymore now. So, but in the past we've been taught about, okay, this patient with BMI, high BMI, probably you have to give this, you have to do that. This patient with low BMI, you have to do this, you have to do that. That's non-existent now. It's not there anymore. So that kind of updating also should be there. Using technology, the world is open, like I said, but you should take that initiative to, you know, kind of improve yourself. That is more important.
No, wonderful, wonderful. This is great. So just to kind of round it off, the one question that I've been itching to ask everyone is around this dichotomy between personalization and privacy. So how do we think about this? Because on the one hand, we're saying we want to put the, whoever needs the care at the center of it. And all of this is enabled because of the data that we get about them. And we're able to personalize the care. But how do we balance this with the needs of data privacy, data security? How do we think about this? How are you thinking about it in your respective areas?
I think in India, we are in a pretty nascent stage to talk about data privacy. First, people should start generating that data, and then, otherwise, in the very initial step, we'll have a block. So I don't think it's just now that people are opening up. You won't believe some of my clients say, just for a CGMS sensor data, they would say, you're invading my privacy. Okay, from that point, we are able to slowly coach them that we need to understand you to give you the right advice, and we are walking footsteps towards you. So let them start sharing data. The key data confidentiality guidelines are always in place. The medical legal aspects of it have always been in place. But if we come up with very strict data compliance guidelines, I think we'll fall flat on our face, at least in a country like India, where it's still a challenge sharing data. The second thing I would definitely say is interoperability is always a challenge. So let's start with data procurement and start sharing data also to the required channels. Interoperability has always been a challenge for more than a decade now. We've been only at the government level, there's a lot of data, but even government doesn't share data. So these are the two major challenges, and that's what I think. We should wait for data privacy guidelines, but patient confidentiality and all, they take care of it for now.
Super helpful, thank you. Mental health challenges, data privacy.
I'm going to take a slightly contrarian view to that one now. I think our entire business is based on confidentiality, right? So for us, it becomes a really critical factor to manage data sharing. So we don't share data with any third parties. We will not share. We will not share data with Facebook, Google, anybody. We just don't share data with them, right? We just won't. And does that hurt our business? Of course it does. But we just wouldn't share data for marketing with those organizations. We chose to get compliant with HIPAA and ISO 27001 when we were a 17 people team 5 years ago, because we said we just lay the foundation now. And that's on the data privacy side. And on the data security side, we use external hacking testing service every year to do sort of all the vulnerability testing for ourselves. Because we really believe that the confidence we're able to give individuals. So we work with over 100+ organizations right now. So across employers, insurance companies, education institutions, for providing services to their stakeholders, right? And so the confidence we need to give to an American Express or a Godrej or a Cipla or a National Law School is anyways quite high. But we believe that actually the confidence that we're able to give to individuals and families that this is a confidential conversation, barring some very, very obvious exceptions around safety, then I don't think people will come and talk about things and in the way that they need to essentially. So I think we are massively focused on data privacy and security as part of what we build essentially. So.
Wonderful, thank you. Anything you would like to add, Sam?
Yeah, so from the point of view of privacy, in the rural areas, most people do not care about the data privacy. They actually don't care what happens to that data because everyone else in the village knows everyone else's problem. However, there are very clear guidelines about both the data security and privacy. At the ABDM stage, compliance stage, you have to comply to it, you have to make sure that you pass all those tests, and only then you are able to call yourself ABDM compliant. So I think that is taken care of. The second part, which is very important part, as to how do we learn, right? How do we put these AI-based model, data-based models into force? So there are two ways, obviously. One is where the patients agree to share their data very clearly for the given purpose as a part of the consent. But if they don't, then government still has a responsibility of creating certain models which are more applicable for the given scenario, geography, right? So I hear there is a plan of making the repository of anonymized data available for processing. Now when the health information provider and health information user basically comply to those norms, there is all the data that is available registered with the government. Of course, data is available with the provider but registered with the government. That can be accessed in an anonymized form at some point of time, I believe, to create such models, and that kind of access will be actively provided by the government to the researchers, research institutes, or whoever wants to access them to build those models. Currently, however, it is limited by the patient consents.
That's a super helpful point actually. So there's a lot of research going on in the space of radiomics these days. So this kind of data is really the anonymization of data, and eventually, going forward, sometimes if you really want to test, because I'm an oncologist with that perspective, you really want to test tumor, you don't have to put in a needle. You can just using that radiomic data collected from like thousands of patients or hundreds of patients, you can probably tell that yes, that's what happens in liver cancer these days. You don't put in a needle, essentially put in a needle. So that's just based on MRI characteristics. How did we come to that? Based on a lot of studies which happened throughout like lots and lots of years. So these days there's nothing like, because if a patient comes for a second opinion, goes out somewhere to a periphery, so they'll specifically ask, this doctor has done wrong. She has not put in a needle and confirmed that it's a HCC. But that's not happening these days. So that's how you mine the data, and you take based on all the characteristics and everything, you tend to come to a conclusion that yes, definitely it's a HCC.
Wonderful. Thank you so much. Last question to you before I open it up to others. Because you spoke about how technology decentralization is actually helping these businesses become viable, I would love to understand, is there anything else that we need to consider for these decentralized models to actually be able to realize the big promise that is ahead of us?
So I would say that in India, and I think one of the panelists said also, India is not one country, right? India is like probably 50 countries, right? I mean, Hyderabad is so different from Bangalore. I mean, forget about everything else. We are present in, like, I was telling somebody, we are present in 112 cities today, right? And each region, each city behaves so differently. Though at a broad level, you think patients are similar, consumers similar, but they are not actually. So I'll give you some examples. Bangalore consumers try and are willing to pay. Hyderabad consumers try, are not that much willing to pay. Chennai consumers don't want to use digital medium to try anything actually. For them, referral is the most important thing, right? I'm just telling you basis our learnings, right? In each city behaves very differently. So today, for any decentralized care to become viable, to become like a real business, you have to really look at your TG well and customize solutions accordingly. And that's the challenge. Anybody who's looking at a pan-India presence will always struggle saying, how do you create solutions which are specific to that particular geography? And that's very specific to India. Of course, technology, the second piece which I think for it to become viable, technology has to be affordable in India. So there are enough and more consumers who want to leverage technology, use technology, don't want to pay for it. They don't mind paying for technology in the hospital. The moment they are at their homes, technology is nice to have. Okay, they will say that everybody wants to use point of care devices. How many of them want to pay for it? So when we give it to patients saying, okay, use it and pay 400 rupees for it, we have one of our partners sitting here. Not every patient will agree to pay for it. They're very happy using it. So any technical solution or technology solution which you create has to be affordable by Indian standards. So I would say running it with a TG focus and creating affordable technology are exceptionally critical for decentralized care.
Right.
Hospital care, everything else works actually.
Fair enough. This is so good. Thank you so much. Thanks for sharing. We'll open it up for any questions that any of you might have. All the panelists are available. Yes, sir.
Hi, good evening. Thank you for this thoughtful discussion. See, being a senior consultant radiologist, I am also an artificial intelligence consultant for a couple of firms. So when we do artificial intelligence projects for our clients, sometimes it's a dilemmatic challenge. You cannot rely fully on AI because we give a particular, kind of a diagnosis and the biopsy comes out totally different. So it's not like it's foolproof. We have to, it's not that easy for us to, take a conclusion, okay, imaging is not, 100% sure. So I think we need to work more on this and not come into conclusions just by, seeing that, okay, this image looks like this. And it's being confirmed by so many people. Like, the surgeons felt this way, but the biopsy came out to be something different. We thought it was cancer, it turned out to be inflammation.
Yeah.
So it's really challenging actually. So I want to add my point to that. Thanks.
Absolutely. No, thank you so much. Thanks for that perspective. Was there anything that you wanted to add to that?
Yeah, absolutely. I totally agree because I'm currently anti-AI right now because so if I want to, for example, doctor is a radiologist. If I want to give him some clinical information wherein he can report it accurately, I'll just pick up my phone, hey buddy, this is what I'm thinking, what do you think? So that part I can't do with an AI. I'm more comfortable talking to a person than typing on an AI. So, and today morning also we had a discussion. One of the panelists was talking about why radiologists are so depressed, because most of the time they're sitting in the dark. So as humans, we are evolved to talk to people, so not sit and report sometimes. So probably I wouldn't agree with the fact that, because most of the radiologists and all, sometimes they really like to see the patients also. Sometimes they do ultrasounds. So I somehow didn't agree with the fact that radiologists are really depressed. No, that's not what it is.
Yeah, fair enough.
Yeah.
Yes, ma'am.
Good evening. I'm Sri Pooja. I'm a clinical psychologist. And the first question our patient always asks us, ma'am, why we don't have insurance for mental health? So I see two of you sitting here who have initiatives on that. So I'd like to have some light on that.
Could you repeat the question?
Insurance for mental health.
Sorry?
The first question the patient
RDI
asks us, like, isn't brain a part of our body?
IRDA is supposed to answer that.
Yeah, thank you.
See, the mental health clinical treatment protocols are so loosely defined still. And in a country like India, we are still not so concrete with that. So that's where, when it comes to paying out of insurance, it's still a challenge in a country like India, where the major complications, the fund that we have to deal with the major complication itself is very small. So that disparity takes a lot to fund that mental health also in India. And I think more proper clinical guidelines are required before we push IRDA to cover for mental health here.
There's 2-3 parts to this, right? So one is that covers come for inpatient care now. So we do get really good cover, comprehensive cover for inpatient care. We've tested it out with our clients now, and that works really well. And where we've been refused it, there have been test cases in the Supreme Court. That's really worked out well. So inpatient cover since 2020, 21, you've begun to see that, right? That's part is happening. I think outpatient cover is a problem in India generally. I don't think it's specific to mental health. I think it's generally a problem in India for all outpatient care, especially, and I think it'll change. I think over the next 5 years, I mean, IRDA has been talking about it for the last 10 years and 12 years now as being a big priority to provide more adequate outpatient cover. But I think again, the third thing is guidelines exist. I think building, we were talking at lunch, building financial models around and payment models around clinical guidelines is not hard. I think where it sits on the priority list of accurate services,
Fund availability
it's very low. Right? That's the challenge in India. Because today you can develop guidelines for most common conditions and that will cover about 80-85% of clients. It is not that different to any physical health condition, right? Because there will always be those 15-20% outliers that you see that you couldn't treat under a specific guideline, but 80% of the clients again would get treated with specific guidelines, and so you can price them, model them easily. But again, where does the priority of insurance companies? Though on the positive side, we now partner with at least 4 or 5 insurance platforms where they are providing mental health services as an value-added service to their clients, and I mean, they pay us, and they provide either absorb the cost of it or subsidize the cost of it for their clients basically. So that's a positive development I think on the insurance side.
Thank you.
My name is Dr. Sai Srivardhan. I am CEO of PRK Hospitals. I have a question for the dignitaries on the dais. Does digitalization of the medical records integration to the national schemes will revolutionize the Indian healthcare system? What do you feel on this?
Is it okay if you repeat your question once?
Does digitalization of medical records and integration of them to the national health schemes revolutionize the Indian healthcare system? What is your opinion on that?
Did you catch the question?
No.
The question
Yeah.
Okay.
The digitalization
Yes.
of medical health records of individuals integrated to the national health policies of the insurance providers, as Sujana has said, like you're due for your EMI. The same way, if our insurance companies or the national health providers who are doing that,
It definitely changes the face of how you manage a patient. Definitely, yes. So, for example, if a patient is being treated in Hyderabad and if he wants to shift his care and establish care with some oncologist in Bangalore, if you have a universal access, you can talk through the system, right? This is what I'm thinking about this patient. What do you think about it? So this kind of cross connect talk can be there. if digitalization happens. So your paper can be lost in the file. So, but definitely that's how the West works, right? You're definitely not given a piece of paper or a file to your hand. Everything is digitalized.
But it's a long way to go. To be fair, it's not like it's not going to happen in a hurry, because I think everybody has to come on board. It's still very
all the stakeholders.
it's like healthcare in general is still very fragmented, right? It has to come on. Everybody has to come on board to basically for it to become a reality. So it's a long time away, but yes, when it happens, it will become like Aadhaar, right? It's like everything is driven by Aadhaar. So everything driven by your health card or whatever you want to call it.
So of course there will be privacy concerns as to who can access what. But other than that, I think it will help.
And not just that, say we really digitize in the near future, we'll get a lot of meaningful data that we are missing out at this point.
You can mine a lot of data.
Yeah, a lot of meaningful data, and definitely that's a game changer.
I mean, that also calls for multi-institution collaborations also to generate a lot of research data, and eventually you can formulate your own guidelines and and tell the scientific community, yes, this data is from India, and can't tell that okay, this is a Western data and we are just extrapolating data to Indian setting. I'm just waiting for that day to happen, but yeah.
Thank you, Doctor, for your feedback. This is Dr. Satya, General Manager Business Operations from PRK Hospitals. Just a note to add for Dr. Sai sir, what he has said. Our hospital is a 220-bedded hospital, 180 is operational. We are actually coming up with probably one of the tallest hospital of 19-story, 1250-bedded coming up soon. But whether it's a 200-bedded or a 1250-bedded hospital, my point which I want to put forward to the forum is definitely the touch versus technology. There are multiple debates wherein touch triumphs technology or technology triumphs touch. One important factor which we need to consider is obviously the cyber security. As Madam also said that we are at the nascent stage. Believe me, my brother works with Microsoft at London. He works for London Police Department where he takes care of the automation. Whether it is LPD or NYPD or Interpol, whatever the cyber security norms they have versus the cyber security that we have currently in our country, we are still at the nascent stage. So the data security is also more important. Added with cyber security, powered AI will be much more better. And only one thing that we need to consider is about the cost effectiveness as well, because setup of 1250 bedded will obviously the cost towards the AI can be pumped in more, but whereas for startup to pump in much towards AI, it's definitely a challenge. Keeping the view of this NPPA guidelines, you have DPCO order, you have got different cappings. So balancing the touch versus technology is obviously a great challenge. But what I firmly believe in healthcare industry is somehow touch always triumphs technology. Let it be a primary care, secondary care, tertiary, or even quaternary care. Even in quaternary care also, where I worked earlier, definitely touch obviously triumphs technology, but we need to maintain a balance for that. Thank you very much.
Thank you for the perspective. Thank you so much. So I think we have time for one more.
There's a gentleman out here.
I think we have time for one more. We'll do one more. Oh.
Good afternoon. Thank you for the very, learning good session. I'm professor in a law school, Santosh. One of the research that I'm doing is right to good health. If you see right to good health as a perspective from the patient point of view or a family point of view, there are so many things that need to be done. And if Vaibhav or Saujanya, anyone is working on CSR, we'd like to collaborate on the research.
Sure, sir. I will take your number. I will come down and meet you.
Thank you. Thank you so much. Maybe last one. We'll do one more. Last.
Gentleman.
This gentleman out here.
He has been
Here.
holding hands.
Hello everyone, this is Dr. Navya. I'm a general surgeon and a cosmetologist. So brochure in my hand with Relive Healthy, which deals with metabolic disorder remission. So with booming diabetes, obesity and diabesity, Dr. Sajanya, I have a question. What initiatives or strategies are currently in place to promote a proactive approach in dealing with these lifestyle diseases?
Yeah. Till this date, what we've been thinking to be proactive is early intervention, early identification intervention, and probably trying to give some lifestyle modification advices and then wondering why are they not working. So that's where we've been there. But now, with the advent of this all the mHealth devices that we are able to, all the wearables, and where we are getting data to understand their lifestyle more than what we thought we knew. There's a lot that can happen in the space of NCD. The affordability goes up, accessibility goes up. I see a lot of cases that are marginally at renal failure, not landing in that chronic renal failure phase, but rather their vessels are getting cleared out. If you really follow up, so there is a lot that we can do at a very nominal cost in the space of NCD with the wearables, with the digital technology. Only challenge that I feel in this space is, as I said, the varied digital literacy. Typically, mobile applications are made for a particular age group or a particular demography. But here, when it comes to NCDs, it pans across. Starts from birth all the way to their death. So that's a real big challenge. If we can really crack that challenge in your near future, NCDs, I feel another 50 years will not see the same metabolic disorders, but some new things coming up with the data that we have misread. So much of data coming out. We'll start misreading all this data, and we'll end up with something new, but not these things.
Yeah. NASH is already on the rise. So.
Yeah.
No, I just want to say thank you to everyone. Thank you to all the panelists. I mean, the perspectives were very, very interesting, especially it's very clear that there is a big promise. And it's also clear that now we are able to make it patient-centric and we're able to do it at scale. But we also discussed the other aspects that we need to consider as we are going towards these models, which is ensuring quality, ensuring collaboration. We spoke about capacity building. We spoke about how it's important to customize our offerings to our target group. So I just want to say thank you for educating me and for educating all of us and for being here. Thank you for being a lovely audience and asking great questions. I hope you have a great rest of your day. Thank you so much. Thank you.
I thank everybody for attending the sessions and also our panelist who's been really great. I would now like to call upon Professor sir for the vote of thanks.
Okay. Last people sitting, standing, whatever it is. Let me do a quick vote of thanks. I think first and foremost, I want to thank the moderators for not only moderating the panel, but also in many places suggesting the panelists. So they actually took a very active role in curating the panels. I think it was wonderful. We couldn't do it. So talk about decentralization. We did this decentralization. We couldn't do it all by ourselves. So thank you for that. Obviously, thank the panelists for being such wonderful panelists, having discussions, disagreements. That was very, very good to see. Thank you for all the audience who are still here, who are patiently listening to the discussion, asking questions. And I met a lot of enthusiastic participants during the breaks. The amount of energy that they brought in and the passion they have for healthcare is wonderful. It gives us enthusiasm and encouragement to continue keep doing this every year. Next, I want to thank the learning champions from our AMPH class who also helped curate this. They were there on the stage, so thank you. I want to thank the MIHM team for curating and organizing this event. My involvement in the event organization was minimal, which could be seen by the success of the event. Okay, so thank you so much, led by Soumya, Satyen, Aman, Vinodini, Milanshu, Mehek, Ares, Mayank, Shvetlina, Pratima, all of you, thank you so much for doing this. And it's not just the MIHM team, but the larger ISB team that made it happen. So I want to thank the IT and the AV team. All our Zoom sessions online, it all went perfectly well. Thank you. The operations team, the engineering team, it may feel a little cold, but we were comfortable throughout the day. So we should thank them as well. And then the F&B and the housekeeping team, okay, goes without saying. They made this happen as well. We were expecting 350 participants. It went up to 550 at peak, and it was managed seamlessly. So it can't happen without many people working in the back end without us noticing them. And I also want to thank our media partners. I think some of them were here. We'll get to hear about the event tomorrow, we hope. And so thank them as well. Thank you, and I will see many of you next year again, I hope so. If you have ideas on what topics to cover and what formats you would like to see, please reach out to the team. We'll see what we can do. Thank you so much.